I just want to thank you for taking the time, not just to improve your education, but also because you're making dentistry better, at least our little corner of dentistry. And you're making the lives of your patients better, so doing a good thing here. All right. I think we should also thank our administrative team here. Farah, thank you. Because they do an excellent job always keeping everything organized and procrastinators like me on schedule. Griffin, thank you. You know, you have excellent judgment in your speaker selection, so good job. The other speakers that were here, I'd like to thank them because they've really kind of de-indoctrinated me and kind of re-educated me as to how I can really help my patients, so thanks, guys. David? Yeah, wake up. Thank you, because David's not a yes guy, and he taken the time to engage me in thoughtful debate, and I always appreciate that. So, all right, and then lastly, but not least, of course, my wife, who is really kind of the brains behind this. She's that rare combination of brains and heart, and so without her, I don't think this would be possible. Speaking of brains, we're going to have to really think about this a little bit because, you know, we've been taught a certain doctrine in dental schools. And doctrines are these things that, you know, you take a complicated topic like perio, and dentistry does not like complicated things. We like to try to simplify things. I mean, here's the problem is that nature does not accommodate our need for simplicity. It is what it is. And so we need to understand that these topics like perio really are more complicated than we probably realize. And this being a complicated topic, I'm going to try to simplify it as much as I can, but I'm way oversimplifying it. I mean, if there were a researcher in this area of immunology, they'd be sitting there going, yeah, but you left out TLRs, and you left out this, and you left out this, and I get that. But I want to try to make this understandable from the standpoint of you trying to communicate this to your patients, all right? Quick show of hands. Who believes, and you know, this is what we're taught in dental school, by the way, right? I mean, if you've graduated in the past 40 years, they've always discussed periodontics as bacterially driven. That is, you ask, what is the primary etiology of periodontitis? And they go, bacterial biofilms, right? So was anyone taught anything different? Raise your hand. What were you taught, David? Tartar. Okay. But tartar was the indirect, how can I say, stuff that the biofilms hung out upon, right? I mean, I've been teaching this for 25 years, and we go through these reviews with the students. They're case reports, and they have to write them up, and every time it's, you know, what's your primary etiology? Bacterial plaque, right? So, but here's the problem. This is a belief. And beliefs are one of these things that, very frankly, you don't have to have a complete set of cogent facts. You know, you can just take certain facts, and then you can kind of mold it, you can kind of make it, you know, something that's plausible. And then you go, this is my doctrine, right? This is what you need to believe. Now, I mean, the correct thing would be to take this and go, well, let's discuss this model. Kind of like, you know, David and I do. We sit around and we debate this back and forth, and what's the merits and what's the problems here. But dental schools, what they do is they say, this is your model, all right? I'm going to take my model here. They don't say, let's discuss this. Can I come over here and do this with you? Okay. They say, we're going to take our model here. Of course, they peel away the facts that don't really fit. So they just kind of peel off, and they kind of mold this into something, and they go, this is my model. And we're going to feed it into your head.
I
Feels better, right? You believe there. See, that's the way to do it, right? I mean, there's no debate in dental schools. They don't go, well, then, what do you think about that? Do you notice that? No. That's what you need to believe, right? So we've all been kind of indoctrinated. I mean, on fluoride, on perio, all these things, right? So now I have to try to undo this. So as we go through this, I'd like to take questions, that's fine, but so if this is the primary cause of periodontitis, and this really should be easy, just get rid of this, everything's done. And when David and I talk about this, I think most of the time we do this and we think, we get rid of the biofilms, we control this, and it looks better. And absolutely it does. But with perio, what we're trying to do is not just make it look better, we're trying to do what? We're trying to prevent them from losing attachment or bone, right? And if we really look at this closely, when I was doing this, I mean, I'm like the funnel, I get all the cases, so I mean, that's all I'm doing. 20% of the cases weren't really responding the way I thought they should. I mean, they looked better, the patients looked much cleaner, they had good oral hygiene, but they were still losing bone. So here's a case years ago. This woman, 59-year-old female, never smoked, good control of her blood sugar, dietarily, no refined sugar, low carbohydrate, gluten-free, vitamin supplementation. She was a technician in a very holistic, pharmacy. Excellent oral hygiene. But she had attachment loss over the prior 10 years. But again, no medical issues. Then she started having problems with fatigue, pain in her back and in her knees. And by the way, this was her habitual occlusion. She was starting to have a progressive open bite. She couldn't get the front teeth together. She was diagnosed with fibromyalgia and rheumatoid arthritis. So she was basically having degeneration of the joints. She went to go see a functional medicine doctor, elevated lead and mercury levels. She went through some IV chelation therapy, but she stopped coming to recall, so I don't really have good outcomes. But I did have, and she didn't want a CBCT either, so she was very holistically oriented. But we did the DNA results, and you can see she had a little bit of Treponema denicola, capnocida, but otherwise she was really, she did an excellent job with her hygiene. So this is what we used to call refractory periodontitis, but but perio didn't like that because refractory periodontitis indicated that we, the periodontists, were somehow failing. We couldn't have that. But we know that this is a thing in perio, and approximately, again, 17%. So it was consistent with what I was seeing too. So obviously I was missing something. Question is, was it something obvious? So here's our choices. When we have observations that don't fit our model, what are our choices? So we can label this an outlier and just ignore it. We can try to make our observations fit the model, like the dental schools are doing. All right? Or we can develop a new model. And this is what I wanted to do. With the question, is bacterial plaque the primary etiology of periodontitis? Now there's a fourth choice in this. What do you think our fourth choice is? Like when we are observing and observations don't fit our model, what do you think? Check your observations. Like, what are we using? So, for perio, our observations are, doing our little probe. But there's certain problems with that, obviously, too. Thing is, we tend to do this according to pocket depths, right? What's the difference, though, between pocket depths and attachment loss? Recession. Who said recession? Move to the front of the class. Good deal. All right? So you have A and B, same patient, let's say before and after treatment, all right? Change in pocket depth? Everybody should be going, yes, right? Pocket depth changed, right? Did you have a change in attachment? You're trying to hide over here. Was there a change in attachment?
Was there a change in what?
Attachment.
Yes, slightly. But the problem is you've got recession, so that changes the number of the pocket.
Does it change attachment, though? No, no. Because what's attachment? How do you measure attachment?
Where the tip of your
Yeah, the top. Yeah, okay. Yeah, you paid attention in class, didn't you? Yeah, okay. Okay, always. All right, yeah, from your dento-enamel junction down to the bottom of the sulcus. That's attachment, okay? In this case, it didn't change. It's absolutely the same. Now look at those two. Is there change in pocket depth here? Is there? No change in pocket depth. Pockets are the same. See, from the bottom of the sulcus to where you measure to the gingival crest, it's still 5 millimeters, right? Is there a change in attachment? Yes, yes there is. Okay, so herein lies the problem. If you're just checking pocket depths, you may be missing the fact that the patients are losing attachment, right? And therein lies the problem. I mean, I present this to my perio students, and hopefully they all understand that. You now as general dentist, now you're thinking, oh, okay, now maybe we need to be thinking about this differently. Okay, so there are some other observations as a periodontist that just didn't fit in with this bacterial model. There's this whole entity. Roy Page is a very meticulous periodontist. I think he's from the Seattle area. He's retired now. But there was this particular form of refractory periodontitis. Excellent oral hygiene, never had increased probing depths, yet they were losing attachment. You can just see. And they have the similar profile of not smoking, they're not diabetic. But what do you notice here? David, what do you notice when you look at this? Look at those class 5s. Like, what is going on there? Like, you got a battery set up in there, don't you? They've got gold foils in there and amalgams. I mean, that is a toxic patient. All right? So this idea of pathogens and disease, you know, there are other articles, and I give all of my references here, so if you ever want to look any of this up, that's fine. But you have these tribes of hunter-gatherers who have, quote, pathogens in their mouth, yet they don't lose any attachment. There's another article, hunter-gatherers, and this is in the Philippines. The other one before was in, I think it was in Peru or somewhere in South America. This one is in the Philippines. And here you have two groups genetically pretty much the same, but one are more traditional farmers and the others are hunter-gatherers. The upshot of this whole thing was the hunter-gatherers didn't really have problems. Of course, they had a much different diet, too. So if anaerobes are found in clinically healthy individuals, are they the initiators? I mean, are they the things that start the process? Or are they opportunists? So this was a review article in Periodontology 2000. This is like the big review journal for periodontists, like where they take all the periodontal literature on one particular topic and then they look at it. And these three are probably the leaders in microbiology right now in perio. Thomas Van Dyke is at Forsyth, very bright guy. But they go through this, and here's some of their comments. Dysbiosis is clearly associated with periodontitis, but whether dysbiosis is the cause or the result of disease is a matter of conjecture. I mean, this is looking at the collective literature now. And even they are saying, yeah, we're not really sure that the bugs are causing the problem. We know that it's associated with the problem, but we're not really sure that it's the cause. Likewise, the molecular details of the microbial stimulus responsible, so they're just saying it in different form here. Should be noted that health-associated species are still present in periodontitis and vice versa. So you still find the same bugs, it's just at different proportions. Significant increase in the total load of health-associated species. So anyway, I'll just go to the graph here. And you see in the health, you still have periodontitis-associated bacteria in the health profiles. It's just that their ratios change relative to the perio ones in disease. David and I were talking earlier about this, and I don't have a microscope. I'm probably going to get one just because I'm interested in doing a study looking at this, but what you have is just a change in the proportion. You have this big upregulated microbiome of these pathogens. So the question really for me is, if the pathogens are always present, is this really an infectious disease? I mean, by definition, you have to have transmission. So if it's always present, how is it an infection? So what could be the purpose of anaerobic bacteria kind of just hanging out in a healthy mouth? What do you think? Oops, sorry. What did I hit there? All right. In a healthy mouth, you have shedding of dead cells, metabolic waste products from the healthy commensal microbiome. So basically, they're there to clean up. So are anaerobic bacteria really pathogens or recyclers? Throw that at a patient. All right? Perhaps you've become recyclable now. Are the bacteria looking at the host going, okay, you've got something I like. Hence, they start to increase. So this would argue in favor that there's some sort of dysregulation in the host that's causing the bacteria. Now, the bacteria take advantage of this and they start breaking things down. Do they cause additional problems? Absolutely. And I'm not arguing against hygiene. I'm not arguing against getting rid of calculus. So don't misconstrue this, all right? You definitely need to do that. Use the iodine. Use whatever you have at your disposal. I mean, you're creating some room so the patient doesn't, break down too quickly. But it's still kind of like bailing out a boat, You're keeping it afloat, but you're not really getting at the core of what's causing the problem, right? Now, you may think, okay, I'm coming up with this. I didn't come up with this. The AAP admitted to this 20 years ago. They came out with a paper. No one put their name on it, by the way. This just was some anonymous committee, because apparently no one wanted to take credit for it. But they looked at the literature 20 years ago, and the factors that lead to the initiation of periodontitis lesions are unknown. They are characteristic of and consistent with two things here. Number one, a subversion of host defenses against bacterial plaque. They're not saying the plaque is causing this subversion of what's host defenses, your immunological system, right? So what they're saying is there's some sort of subversion going on, not naming what this subversion is. And then number two, subsequent activation of a bacterially induced host-mediated process that destroys periodontal tissues. What do we call a host-mediated process that destroys tissues? Hallelujah! Right? Autoimmune. This is the term that periodontists are loath to mention. You can go through that whole Van Dyke article. They do not mention autoimmune once in that thing. They figure out all these different ways to say it, but they never say autoimmune. Why? Because periodontists don't want to have to deal with the whole patient. They want to deal from here to here, and that's it. This is where you folks have an advantage. Yes, work on the hygiene, work on the calculus, absolutely. But at some point, in some patients, they're still going to lose bone. And you have to be prepared as holistic practitioners to be ready to deal with that. And that's where Phil, Bob are going to talk to you about treatments. I'm just talking about etiology today, okay? A little bit about diagnostics. Now, can you have an autoimmune disease that has a bacterial component that makes it worse? Sure. Can you name one? Rheumatoid arthritis. Really? Do we treat that with antibiotics? There you go. Okay? This is not the only autoimmune disease with a bacterial component. If you go to the AAP education website, is periodontal disease contagious? Well, you know, if it's an infectious, it should be contagious too, right? Well, we've already shown it's not really infectious. They even admit, technically, it's probably not contagious. But if you read that whole thing, they're trying to convince you that it is. Like, they can't make up their minds. All right, so patients lose attachment without ever having, I'll just go through this. Does not behave according to Koch's postulates. It's not infectious, not contagious. We can't reproduce it in an animal model by infection alone. Research supports the concept that this is an autoimmune disease with a microbial component and not the other way around. So there's this subversion and then this autoimmune degenerative process. So this is where the bioregulatory piece of this comes in, and I'm going to try to move through this quickly and apologize. But bioregulatory medicine looks at this from basically how do we maintain homeostasis? How do we keep these processes that keep us alive, functioning, and thriving, how do we keep them in balance? Blood glucose regulation is an example of that, right? You have all these systems that try to keep your blood glucose in balance. I'm just going to pop through that. You have, in bioregulatory medicine, you have these bioregulatory planes, and I'm not going to try to explain all these, but what I want to point out here is that in bioregulatory medicine, you have this correlation to these hierarchical levels that we as allopathic trained people understand. The only one that doesn't really match completely, I think, is that psycho-emotional and the biochemical pathway. But, when you think about it, in medicine, how do we try to treat with psychiatric problems? Prozac, and we're just giving, we're trying to manipulate these biochemical pathways, right? So what I did was I just started looking at the periodontal literature related to all of this stuff, and there's just tons and tons of periodontal literature related to all types of disease, but even at these various levels. I mean, this is not a complete list here, but I'm just saying, look, you've got anatomical level, tissue, organ, microbiome level, cellular, subcellular levels of dysregulation, biochemical, genetic. I mean, when you have a patient with active periodontitis, you have a sick patient. It's not just from here to here. So patients need to understand that. And you've got plenty of information to back you up on this, all right? So don't be afraid to get that to patients. Now, they may not understand that they have some other problem. Sometimes patients come in and the first thing that they're really understanding or realizing is that I've got bone loss around my teeth. Do they know that they have any other problems? No. But so many times, sometimes we're the first ones to notice that they've got a problem and that they need to get checked out. And preferably by integrative functional medicine doctor, because most of your other allopathic physicians, they're like, do you have a problem? Yeah, my dentist said I'm losing bone around the teeth. And they go, well, so what? They don't care. All right. Point is, these are not healthy patients. All right, so we're trying to organize this, and I'm going to try to get through this quickly, but much of how traditional medicine is based on the cellular theory, and if you only study from the cell level, it's kind of like trying to study forestry from the level of a tree. You know, you need to know everything about the forest, right? You don't really understand how the tree interacts with its environment. I threw this in here just because this is an excellent book. Phil, Bob, thank you for putting me onto this, because without those two guys pointing me in this direction, I would have never gotten onto this. I just knew that something was wrong. These guys helped to point me in the right direction. Most of the cell's function and behavior is based on how it responds to its terrain. So, we're going to take an oral epithelial cell as an example, because there's all these studies on how P. gingivalis and how all these other pathogens are toxic to either fibroblasts or epithelial cells, but this is in vitro. In vitro is a long way from in vivo, meaning in vitro they're looking at it in a petri dish. That is not the same thing as looking at it in a human. So, for an epithelial cell, its function is to keep stuff out, right? But they need to act as a group. So you get these studies where they're looking at mixing in P. gingivalis or some other pathogen in with it. Oh, look at all the things that happen with this. Well, of course, because they cannot function as a group. They'll try to organize themselves, but after a few days, they start to become spindle-shaped. Because they don't have a basement membrane, because they don't have an extracellular matrix. So this whole business of studying bacterial virulence factors, as they like to call it in perio, is just misguided. You don't have immunoglobulins, you don't have your immune system, they don't have their normal connections. To function properly, oral epithelial cells need to be connected to each other. They need a basement membrane and the connective tissue. And if you start to take some of these other courses, you'll find this, what we call dermis, is something actually much more. It determines the physical characteristics of any tissue, whether it's bone or the cornea, extracellular matrix, all right? It's the dermis. It's where all the action happens. It's found in mammalian physiology. It's described as connective tissue, but it's much more important than that. And for bioregulatory medicine, this is kind of what they tend to focus on. All of these functions, lymphatic, neurologic, immunologic, nutritional exchange, barrier, circulatory, genetic expression, all happen here. And when you start to have patients with oxidative stress, which is, again, heavily associated with perio, we understand that it's not just for perio, for a lot of other diseases, but because this is an area that's easily accessible, it has a high turnover rate of cells, a lot of times you're going to start to uncover these problems that patients have with toxins in the mouth probably before anywhere else. Like the patient that I had, she had this attachment loss. She looked good. She, kept good hygiene. She didn't have any pocketing, but the tide was going out. Know that oxidative stress plays a role in periodontitis. So does oxidative stress of the ECM have any effect on epithelial cells? Well, yeah, it does. I'm just going to fly through this because I don't want to get into too much in the weeds here. ECM becomes dysregulated. Its ability to remove waste and toxins is compromised. Integrity of various junctions and connections. All this starts to break down. You can think of them as like hooking arms with each other, and now when the ground underneath them is becoming toxic, they start to lose their connections. So what happens? Now these tight junctions and connections open up, or in other words, the patient becomes leaky, right? How many times have we heard leaky gut? It's leaky mouth. Breakdown of the barrier function allows opportunistic microbes to access the nutrient-rich and somewhat toxic ECM. How does the host respond then to this? Well, you've got these things called Langerhans cells, and then you also have dendritic cells. These are part of your innate immune system. It's constantly looking, patrolling, seeing what's going on. If it sees a pathogen, say like Treponema denticola, on the epithelial side, it signals everything's okay, immune tolerance. Don't anybody get upset, start doing anything yet. But if you see it on the other side, if you see it on the ECM side, then that's when the action starts to happen. The dendritic cells then start to hand off these messages to the CD4 cells, and then you're going to get all kinds of action. All right? Again, this is what I was mentioning. All right? There's the references for you. So there are a variety of other cells that will also detect the presence of anaerobic bacteria on the wrong side of the basement membrane, and that they will then produce cytokines that influence this programming of the CD4, these T cells, because then that's when you start to get your what's called your adaptive immune response. And that's what starts to cause all the problems then. So this is where they start to talk about IL-17, and Perio tends to talk about IL-17 as like, that's what starts to cause the autoimmune problems. Well, IL-17 has a rational function. It's not there to cause autoimmune. Like, why would you have a cytokine to cause autoimmune problems? Like, genetically, like, how would that make any sense? These interleukins are basically designed to regulate epithelial tight junctions, induce antimicrobial peptides, and then to release neutrophil chemoattractants. So they have a function, but it's not to induce an autoimmune response. It's what happens is when they come in, IL-17 comes in and it's supposed to be doing all these things, and it doesn't work, and the response, the leakiness becomes chronic. That's when you start to move into autoimmunity. You have this decrease in Langerhans cells, you have an increase in the neutrophils and the plasmacytoid dendritic cells. That's when things start to go off the rails. So to summarize, in health there's this balance between innate and adaptive immune cells. In periodontitis, you have this preponderance of pro-inflammatory adaptive immune cells. But then the question is, why do we get the bone destruction? That's because of this failure to seal the breach. Inflammatory response becomes unregulated. You have this disruption of the connective tissue and autoimmune homeostasis. What they call the rank L to OPG becomes unbalanced. I mean, if you put this in front of a periodontist, they'll go, oh, okay. I mean, I put this actually in front of my graduate students and some of the faculty. And I got done, and then they were like, I mean, I could see the cogs turning and so forth, and then they're like, yeah, and they had good questions, but, you know, then they're like, well, why was the AAP saying this? And I'm like, that's a really good question. Maybe you should talk to somebody at the AAP. I mean, it's not that they didn't believe anything I had to say relative to the physiology that I'm presenting. They were like, well, why is the AAP telling us this? You know, suddenly lights were going on, just like, you know, when you're suddenly discovering that mercury is not a good thing, right? So here's the question. So what's causing this chronic disruption of epithelial barrier function that doesn't allow them to maintain their barrier function? Could it be a matter of toxins? We know that they affect GI epithelial barrier function. Problem is, no one's really done good research on this relative to oral disease. Now, Dave may correct me on that. I don't know. Immunotoxicology, I think this is what we really need to be focused more on relative to perio. We know that the main factors that the AP associates with perio are smoking and diabetes. Well, both of these produce toxins that affect the homeostasis of the ECM. It also affects free radical status. I mean, typically when we talk about oxidative stress, we always think of oxidants versus antioxidants, but really what this is about when we talk about mitochondrial function is it's really the electron transport chain. And that's where these toxins really start to act, is on the electron transport chain. Mercury, again, disrupt barrier function, immune regulation, and even the electron transport chain. So it's like the triple threat. And we have epidemiological studies to back this up as well. Okay, Korean study. So inferring bacterial pathology, again, through these cell studies is just not correct. Functional parenchymal cells, they have to communicate with each other. ECM, we talked about that. Again, autoimmune disease, bacterial component. Here's the three things though. Damaged barrier function, dysfunctional innate immune system, and the electron transport chain being disrupted. And if I had to kind of focus it down to maybe just one thing, it'd be the electron transport chain, because that is the energy for the cells. So, diagnostics. So, yeah, so when I presented this to the science committee, it was like, well, okay, so what are you going to do if you have a patient that they don't really show any signs, but you think that maybe they've got one of these problems? So how do we discern that a patient has attachment loss if there's no clinical signs of inflammation? So during this previous, I was showing you this pathway. There's an alternate pathway. Does this have a laser on it? I don't think so. But you see over here, there's a pathway that goes over towards the neutrophils and the fibroblasts. And in this particular one, you see that they produce reactive oxygen species, and they produce MMPs. MMPs are matrix metalloproteinases. Periodontists love to talk about those. The problem is we've never had a test for that. There's this complex interplay. Basically, you always have these MMPs around. It's just that we've never had a test to find out how are they activated, or to test when they're activated. But we've got one now. And this just became commercially available, I think, within the past year or two. I don't know if anybody has this particular oralizer. Does anybody have one of these? Okay, because I just got mine like a week ago. It's an interesting test. I've been following the research on this for like 10 years. It's by this guy, Timo Sorsa. I think he's out of Finland. And they used to have a machine for this that was probably about this tall. It wasn't really practical for a dental office. But in this one now, you can sample this, I think, by 3 different means. You can, like a whole mouth rinse type of sample. You can do pooled sites. You can do individual sites. So what about the microscope? I think this can be a useful tool if we interpret it properly. And Dave and I were talking about this earlier. Because, you know, if you have patients with occasional spirochetes here and there, I don't think we should necessarily get like too upset. But as Dave was pointing out, if you have lots of spirochetes and lots of white blood cells, you got a problem. Okay, so I mean I think that's probably. But the mere presence, and this where maybe Dave might, I can say, disagree with me, but to me, just having a presence of 1 or 2 or 3 probably doesn't indicate disease. But if you got a lot and you got a lot of white blood cells, then you definitely have a problem. All right? But really determining the level, we haven't really, I mean, you can go in and there's tons, no, I would say tons, there's several articles looking at using microscopy to try to determine disease and disease progression. The thing is, I think most of those studies didn't really use it effectively. You know, sometimes periodontists will use these things that they feel threatened by and then purposely set up the study to make it fail. And I've seen that several times. So this is my professional definition of chronic periodontitis. Here's the patient one. This is an autoimmune disease that has an infectious component, causes you to lose bone and gum around the teeth. It's a result of toxin or toxins that inhibit your body's ability to generate energy, keep out and defend itself from microbes that constantly seek to recycle all of us. You can use it if you want. If you don't, come up with your own. Educational challenges. So, of course, dentistry is not going to like this. It's what I talked about, that it's a chronic autoimmune disease. Need to get beyond brushing, flossing. It's still important, though. So I don't want to dismiss that. But we need to get on with proper diet, exercise, oxygenation, sleep, and other regenerative interventions. And that's what I'm going to let Phil and Bob talk about. There are physiological aspects in periodontitis that need to be evaluated for medical. So you should be working, especially with these patients, you should be working with a functional medicine or a naturopath. Does anybody use the mitoswab for mitochondrial function? Have you used that, Bob? Phil, have you used that? Mitoswab? No? Okay. I just found out about it. Somebody, I forgot, maybe it was Woz or somebody was using that. Oh yeah, I skipped over nitric oxide, but maybe one of you guys will talk about that. All right. Sorry, I threw a lot of stuff at you guys. I apologize. Questions? Or do we have time for questions? Yeah? Okay. I got that in how much? 40 minutes? Wow. All right. Hot dog. Oh, man, come on, I didn't blow you guys away. Do you have a question? Sorry, I'll have to give the microphone. Sorry. Yeah, she's over here. Sorry, I have to do the microphone thing.
Okay, so my question is, once you have the immune system under control, like the patient is seeing a doctor that's taking care of the immune system.
Right.
Can you do a bone grafting? Or
I think if you get the patient to that point, now that's usually not an easy thing to do. You know, I guess if you look at I think Bob and I were talking about the Reykjavik's matrix of homotoxicology. You know, if you had to put like a perio patient on that, they have like 6 levels of how dysregulated a patient is. And I think, you know, if you're at level 6, you've got like cancer. Perio, you're at level 5. So you have a really, really dysregulated patient. So getting patients out of that, I think, is really difficult. And I mean, I'm almost universally, when I see a really active perio case, I mean, one of the things you really should be doing is like getting rid of all their, and you don't want to like jump in right away with this, but I mean, they should get rid of their mercury in their mouth. Now, how you do that, though, I think is really, you have to be very careful with those patients because they're like a glass that's like this full. And then you're going to go in and you're going to start You know, you need to get them to a functional medicine person who really knows how to get them detoxifying at least as well as they can, and then start to, yeah, again, I don't want to get into fill stuff though, but yeah. But good question. Yep. Would I do a bone graft if they were re-regulated and healthy? Yes. Yeah, sure. Yeah, absolutely. Yes.
Where at?
Yeah, sorry. Yeah, we got to do the microphone thing.
Okay, so you talked about IL-17 inducing peptides for kind of that immunological cascade. Has there been any studies looking at exogenous peptides, how that can kind of help the defense system?
Yes, that's a really good question. I think, are you going to get into peptides in yours? In your presentation on biologics? No? Okay. Peptides, I think, are really interesting, especially in immune regulation. If you want to talk later, like one of my functional medicine guys is coming in here who's really good with the peptides. And he's like one of the few that I know in the States that are using these peptides to re-regulate or to basically to regulate the T regulatory cells. He does this by using a peptide that sits on the major histocompatibility complex 2 to try to, so basically my mother-in-law has perio, she has rheumatoid arthritis, and she was just in awful shape. And he started doing this peptide therapy, and it was like, and I have several of his patients, and I mean, to a person, they would start to do this, and they were like the Tin Man. They were like, and then he would do this, and they'd come in the next day, and they were great. And for 3 weeks, they'd be fantastic. And then but he would do this successively with them to try to re-regulate their immune response. Now, at the same time, you got to, detoxify them. You got to get rid of heavy metals. You got to do all these other things. But now she's at the point, and this is like 3 years later now. She comes in once a week. She gets her IV ozone. She gets her vitamins. And she's good. I mean, we were injecting her knees with ozone and her hands and fingers and shoulders. And now she's like, she's 82. She just turned 82. She drives her car. She goes to and from her English classes. My wife is Venezuelan. And she does fine. She's functional. She was in bed before. She couldn't even hardly get out of bed. So peptides, yeah, I'm like all over that. So yes. Sorry, long answer to your question, but yeah. Anything else? Yeah, great question, though.
So what do you do with the patient that had the severe bone loss, but no signs of inflammation, no bleeding, nothing like that?
Well, again, that's still a patient I would be talking to about, like what kind of physician are you seeing? Because we need to dig deeper on a patient like that. I mean, if you can note that they've got active bone loss, like that other patient, because I kept telling her, you need to go see a functional medicine doctor. I mean, even at that point, I knew something was not right. And so she finally did, and she got the heavy metals, but she always kind of resisted a little bit, even though she worked for a guy that was very holistic. And she was in that way herself, too. I mean, she didn't want to do any scans or anything. But I don't know. It just seemed like I couldn't really get her to really engage as much as I wanted to on this. So I'm sorry, I went off topic there, but did I get to your?
Yeah. So just dig a little deeper to find out.
I think you really need to dig deeper. I mean, I do blood chemistries on almost all of my patients. Okay. Just to, if they don't already have a functional medicine person. I mean, I do not do any implants on anybody unless I've got a blood chemistry, unless I've got a vitamin D level, unless I know what their iron levels are. I mean, there's a number of things I have to know before I start doing implants or start taking teeth out and stuff like that. So it's just saved me from a lot of headaches. Okay?
Thank you.
Yeah, sure. Okay. Is that it? Bob?
You and I talked about this before, but I just wanted for everyone to know, does Dr. Logan have a recommendation for supplements for the autoimmune component of periodontal disease?
That is a really good question. I think we're probably going to have to talk to him.
Okay, I know we talked about upregulating T regulatory cells versus the TH14, the 17 is the one that tear down the bone.
Right.
So, yeah.
I'm sure, and I don't know that he has like a set one, for autoimmune problems. And very frankly, every time I think I know, the next time I talk to him, it's different. Like he's like he's constantly researching and constantly looking, and it's like if he finds something better, then he changes, or something that works better. So, that's why I work with him, because he's always on top of these things. All right. Well, thank you.